Okay, Dr. Vito, you have the floor.
Thank you very much, ma'am. Good morning, senior colleagues and colleagues. I'm Dr. Victoria, and I'll be taking practice question 2. Mr. A 45-year-old man, presented to accident and emergency department with sudden onset of left-sided body weakness and facial weakness while passing urine at night. He had a prior history of severe headache with the onset of symptoms. He is a known hypertensive for 1 year with poor drug compliance. He does not smoke or take alcohol. However, he consumes marijuana and cocaine occasionally. His father and elder brother were both hypertensive and died of stroke. His blood pressure 120, 220 stroke 120 millimeter of mercury, and the pulse rate is 60 beats per minute. The first question says, list of first differential and 6 causes. This is the picture showing Asia view of brain CT scan. Then the first question, list 4 differentials and 6 causes. 4 differentials include intracerebral haemorrhage, subarachnoid hemorrhage, cerebral infarction, or intracerebral abscess. 6 causes, using my first differential, intracerebral hemorrhage, hypertension, cerebral amyloid angiopathy, arteriovenous malformation, clotting abnormalities such as bleeding disorders, or use of anticoagulants such as warfarin, heparin, and individual with hemophilia. Use of illicit drugs, abuse of illicit drugs such as cocaine and ketamine. Ruptures of intracranial aneurysm such as berry aneurysm or mycotic aneurysm. The next question says, describe your findings on the image. As I've said earlier, this is an axial non-coastal computed tomography scan of the brain of Mr. A 60-year-old man. Now, there on the right hemisphere, there are areas of hyperdense collection in the right basal nuclei with surrounding hypodensity. This is hyperdensity. This is the hyperdense collection. This is the surrounding hypodensity consistent with edema. There's also a midline shift to the left. A midline shift to the left. Where a midline shift to the left from a mass effect. There's also obliteration of the lateral ventricle from the mass, obliteration of the lateral ventricle from the mass effect. List other questions you will order for and why. Well, these are the brain CT scans confirm that we're dealing with intracerebral hemorrhage. So other investigations that I will do, especially to rule out other complications of comorbidities, include I would like to do a contrast enhanced CT brain scanning, which may be useful in identifying risk of hematoma expansion. It may also reveal the etiology, such as heterovenous malformation. Then also, I also want to do computed tomography and angiography. This is to rule out other differentials, such as or complications, such as subarachnoid extension, or to rule out subarachnoid hemorrhagic stroke, which is a close differential of the intracerebral hemorrhage. It is said to have greater than 99% sensitivity. I also want to do coagulation study, prothrombin time, international INR, and activated partial troponin time, especially in patients on anticoagulant, to evaluate for evaluation of possible coagulopathy. I also want to do electrocardiography or cardiac exams, such as troponin or high, to evaluate possible myocardial ischemia, which could be a complication of hemorrhagic stroke. I want to also do toxicology screening, toxicology screening to detect the etiology of hemorrhagic stroke, such as use of cocaine and amphetamine and marijuana. Also, auxiliary investigations to rule out comorbidity or complication, such as glycated hemoglobin, to rule out diabetes mellitus. Full blood count to know whether there is a low platelet count, which could be a risk factor for, which could be responsible for bleeding. Then the extra UL creatinine to rule out that other complications. Discuss your principle of management. The principle of management of stroke in general includes resuscitation, radiological evaluation, which is important in the diagnosis of hemorrhagic stroke. This will help us to, is pivotal to let us know whether it's infarction or hemorrhagic. Reperfusion, reperfusion is especially for infarctive stroke. Recurrent prevention, retard progression of comorbidity, reduce the risk of complications and risk factor modification. Rehabilitation, which is very important in the management of patients with stroke, whether ischemic or hemorrhagic, such as physiotherapy, occupational or speech therapy. Now, going to our diagnosis, intracerebral hemorrhagic stroke, I want to manage this patient in stroke unit, that's the ideal thing. And multidisciplinary approach is necessary, which must include neurologists, physician, family physician, stroke unit nurses, physiotherapy, speech physiotherapy, occupational physiotherapy, neurosurgeons, and social workers, family physicians, and so on. Radiology is also important. I want to do neuroimaging, non-construct brain CT, which is pivotal in the diagnosis of intracerebral hemorrhage. I want to ensure intensive BP lowering, 25% of mean arterial pressure in the first hour, and I will lower to 160 stroke, 100 milliliter of mercury in the next 6 hours. And I also want to meet my BP target goal, which should be optimal, should be less than 140 millimeter of mercury in the next 48 hours. A potential treatment of hemorrhagic intracerebral hemorrhagic stroke is surgical evaluation of subject evacuation of hematoma by neurosurgeon if indicated. Then also rehabilitation is very important, which is multidisciplinary, which include physiotherapists, occupational therapy, speech language or swallow therapy, use of also music therapy. What are the risk factors in this patient? Based on the risk given, the risk factor in this patient is hypertension with poor drug compliance, first-degree family history of stroke, use of cocaine, and marijuana. These are background informations on stroke. Definition of stroke, the older definition, the new definition now, talking about objective evidence of infarction or hemorrhage, irrespective of duration of clinical symptoms. It is focal and not global, unlike the previous definition. Now, the various types of stroke include cerebral infarction, intracerebral hemorrhage, cerebral infarction, intracerebral hemorrhage, and subarachnoid hemorrhage. In the neuroimaging given in this case, in this question, this is intracerebral hemorrhage. But we should also look at other types of stroke, which will...
Chief, please, you have 1 more minute. Can
okay.
you round up, please?
Okay, these are the other type. This is for ischemic, hypodensity. This is for subarachnoid. This is for intracerebral hemorrhage with subarachnoid extension. This is another picture. Cerebral infarction stroke is the commonest, about 80 to 85%, while the intracerebral hemorrhage we talk about is just about 10%. These are the risk factor, modifiable risk factor, non-modifiable risk factor, novel risk factor, intermediate risk factors. Those are the subclassification of the three types of stroke. And this is table showing comparison of ischemic versus hemorrhagic stroke. However, the main thing is the neuroimaging, which is evidence, as the history and finding on examination are not objective, they are subjective. This is the cerebrovascular anatomy. These are the clinical features of patients with stroke, and these are the principles of management generally for stroke. Now, for treatment of hemorrhagic stroke, you want to ensure basic life support, you want to control bleeding, you want to address seizure, you want to also ensure deal with intracranial pressure, if there is raised intracranial pressure, you want to do decompression. So you want to give anticonvulsant to prevent seizure reoccurrence, antihypertensive for effective blood pressure control, and osmotic diuretic to decrease intracranial pressure. As I've said, neurosurgeon might in the management of hemorrhagic stroke, neurosurgical consultation is needed in case there will be an indication for surgical evacuation of hematoma. For other forms like subarachnoid hemorrhage, surgical clipping and hydrovascular therapy using coil embolization are also used.
Can you wrap up?
Okay. These are complications of stroke. Thank you very much. These are my reference. Thank you.
Oh, thank you so much, Dr. Ibitoye, for that beautiful, lucid, concise, and thought-provoking presentation. You already have a lot of reactions on the chat. It was a very beautiful one. So let's keep the thanks coming. Thank you so much. Let's keep it coming. Okay, so I'll just go straight to the chat. We have a lot of comments already. Okay, so Dr. Olalekon says, good morning. I think the first differential diagnosis should have been acute right hemispheric hemorrhagic stroke, considering the presentation of sudden left hemiparesis. And then other likely causes of stroke in this index patient are inherited stroke symptoms like the CADASIL, I guess the second one was supposed to be CARASIL, the Bellas and Padma, considering the family history of stroke in the father and the brother. Thank you. Babite, do you want to react to that?
Yes, I totally agree with him.
Okay.
To be specified, is the history think there was acute stroke, and this is hemorrhagic stroke.
Okay, because you were not very specific in your diagnosis. Okay, so maybe we'll add that. Then the next, Dr. Justice BT says, good morning. Thanks so much for a good presentation. Why do you have to request for a contrast enhanced CT when you already have a non-contrast CT that's already showing the bleed, showing the lesion? And then did you mean CT angiography? And then let me just add to that question. If you meant CT angiography, I think there are some kinds of stroke that don't require CT angiography. I stand to be corrected. Okay, do you want to react to that?
Yes, thank you for that question. The question says, what other investigation will you require for? And that's why I specify that you might want to evaluate further, especially in patients with intracerebral hemorrhage who had a subarachnoid extension, which could be a complication. A contrast CT will be needed to evaluate and identify the risk of hematoma expansion. So we are not requesting for the contrast to make diagnosis, but we want to identify whether there are hematoma expansion or to rule out other etiology of hemorrhagic stroke, such as intravenous malformation. That's the indication for requesting for contrast enhanced CT scan after the initial non-contrast enhanced CT scan. Then the computed tomography and angiography is also usually used in the evaluation of patients with subarachnoid hemorrhagic stroke because non-contrast CT scan is not as sensitive as the computed tomography and angiography in the evaluation of patients with subarachnoid hemorrhagic stroke. Now, in intracerebral hemorrhage, subarachnoid extension is possible. So, for further evaluation of the subarachnoid extension, that was the reason for request for computed tomography and angiography.
Okay, I was just thinking. I said if the non-contrast could show this bleed, won't it also show the SH? Okay, maybe we'll have a neurologist throw more light on that later. Okay, so Dr. Maduka is saying other risk factors include male gender and black race. I'm assuming he's black. Okay, you didn't add this to your risk factors. Then your management.
The question did not specify that the patient is black.
Okay. So Dr. Ibenabo is saying your management should include neuropsychiatric evaluation because the patient's on cocaine and marijuana, he would need rehabilitation. I think so too.
I totally agree to that.
Okay, so you'll add it to the slide before you send it. Okay, thanks for the presentation. Dr. Mamadou Jafari is saying thanks for the beautiful presentation. Please, what's the source of the new definition and the year? Actually, I would like to see that too. Do you want to react to that? Or you want to study later?
I got that definition from the update slide of Professor Ogun. So I'll search on the internet to know the national guidelines he quoted.
Okay, so Dr. Charles Okoro is saying thank you for the presentation. Okay, thank you for the presentation. Are anticonvulsants given to prevent seizures without the patient having seizures? Like, do you do prophylactic for seizures? Is it routine?
No, what I said is that it's given to prevent reoccurrence of a seizure, which means patient has seizures. You want to give anticoagulant. So I'm not sure maybe it's used for prevention.
All right.
The patient will have the seizure.
Okay, so Dr. Becky Obas is saying, thank you, sir, for the presentation. How about management of risk ICP? Is it necessary in those patients? Okay, I think that's a valid question because, you know, when you were talking about mass effect, I think the mass effect was due to perilesional edema.
Yes,
So
I said that in the management that monitor will be used for decompression.
Okay, are there other forms of management for the ICP?
Apart from the monitor,
yes,
I'm not sure. Maybe the neurologist.
Okay. Okay, so you have a lot of thanks. Dr. Winke is saying thanks. Dr. Abimbola is saying thanks. Dr. Maduka is saying thanks for the beautiful presentation. Dr. Adiboka is saying thank you for the beautiful presentation. Please, can you throw more light on your BP management?
Okay, I said the reduction of blood pressure in intracerebral hemorrhage must be intensive. In the first 1 hour, you have 25% reduction of the mean arterial blood pressure. And in the next 6 hours, you want to ensure that the blood pressure is reduced to 160/100 millimeters of mercury. While the target BP in patients with hemorrhagic stroke should be less than 140, 90 millimeters of mercury. And you should ensure that in the next 48 hours. Intravenous medication such as IV labetalol infusion are used in the control of, can be used in the lowering of blood pressure in patients with hemorrhagic stroke.
All right, thank you so much, Dr. Kalamama is saying thanks for the detailed presentation. Dr. Amako is saying ensure fluid management, monitor, okay, prevention of DVT, secondary prevention, and then rehabilitation for him. Okay, so that's an add-on. Dr. Okute is saying thank you for the lucid presentation. I didn't hear your management of ICP. Okay, he has talked about it. What about glucose and temperature control? Did you talk about that? Talk
No,
about glucose
that's
temperature.
also part of it. Temperature control, glucose control. If they are hyperglycemia or hypoglycemia, you want to also optimize either way, either hypoglycemia, hyperglycemia. You want to optimize.
Okay, so maybe you add all this into the slide: blood glucose control, temperature control, neuropsychiatric evaluation. Then Dr. Araga is saying, thank you for the beautiful presentation. Okay, he has already talked about the blood pressure. Maybe neurologists add more to that. What are the options for prophylaxis for DVT?
Use of tests. Okay, in patient with hemorrhagic stroke, you don't want to use anticoagulant because that will increase the risk of bleeding and leads to hematoma extension. Use of test stopping for the patient while patient is on medication. Then I'm not too sure the duration of time in which you can commence anticoagulant in patient with hemorrhagic stroke. But I know in the acute phase, oral or parenteral anticoagulants are contraindicated in hemorrhagic stroke.
Okay, thank you so much. Okay, so Dr. Ibe Kasidi is saying anticonvulsants may be beneficial in cases of subclinical seizures in hemorrhagic stroke. Okay, we've talked about that. Dr. Maduka is saying, I think the patient may actually have SAH looking at the brain CT. There's blood tracking the brain system. Could be confusing sometimes. Okay, that's just his thoughts. Okay, so let me go to the okay, so we have some hands up. Okay, so Dr. Adebimpe, you have the floor.
Okay, good morning, teachers. Okay, good morning, teachers and colleagues. Thank you, Dr. Ibitoye, for the lucid presentation. So in addition to what you said, as regards the CT, the contrast CT and CT angio, I think it's just safe to say CT angiography. The radiologist will decide if they want to give contrast after the CT or not, but it's just safe after the CT, non-contrast CT, to do a CT angio. The CT angiography will help to identify if there are arteriovenous malformation and specify the type of malformation, if it's an aneurysm, the location, and the size. So that's why CT angio is important. Then as regards management of the raised ICP, in addition to what you said, it's important to nurse this patient 30 degrees head up. It will help to reduce the high CP. Just elevate the head of the bed 30-degree head up. And in addition to the mannitol, also some hypertonic solution can be used, hyperosmolar solutions like hypertonic saline, 3% hypertonic saline. But the commonest in this environment that we use is 20% mannitol, given as 0.5 to 1 milligram per kg, and it's given as a bolus. It's not given slowly, it's better given as a bolus. Then other supportive care, which are very important: glucose control, temperature control, like has been mentioned, prevention of DVT. For prevention of DVT, it's better to use graduated compression stocking. Those are the tech stocking in graduated form. Then also intermittent pneumatic compressive device are also very important, though not readily available. It's advised to delay the use of anticoagulants until after 3 weeks, when you are sure that hematoma expansion or rebleed would not have occurred. Then it's a multidisciplinary care. You have to involve the nurses, the physiotherapists, the occupational rehabilitation, and all that. Then it's important to reduce the BP so as to prevent hematoma expansion, like you said. And apart from giving IV labetalol, you can pass NG2 for the patient and also start oral antihypertensive. Like you said, the target BP is less than 140/90. So thank you very much. Then also for this patient, one is to think about the genetic cause. Mind you, the father and the brother also had stroke from hypertension. It would be better to evaluate this patient properly for that. Thank you so much.
Thank you so much, Dr. Adebimpe. That's one of our neurologists in the house. Okay, Dr. Kalamama, I saw your hands up. I don't know.
Just an add-on to what Dr. Bimpi said as regards treatment of raised ICP. The patient can also benefit from hyperbaric oxygen. Patient can also benefit from use of acetazolamide and then steroids. Then again, I want to find out, do we have to use contrast in this patient when we know this patient has a bleed? Won't it cause an irritation to the brain parenchyma? Just thinking aloud. Then also for the investigations, I don't know if carotid Doppler would be helpful for this patient because I think a differential can be right hemispheric ischemic CVD with hemorrhagic transformation. So I don't know if carotid Doppler will be useful for this patient as one of the investigations to check the circulation of the arteries at the neck to rule out maybe atherosclerosis or then stenosis. Then also for the brain imaging, one other feature that was seen was loss of white gray matter differentiation, and then there was effacement of the sulci and the gyrus, which showed the patient had cerebral edema. Then lastly, a differential can also be right hemispheric intracranial space occupying lesion with hemorrhagic transformation, and then also this patient can also have a right hemispheric ischemic CVD with hemorrhagic transformation, just an add-on to these differentials. Thank you so much. It was a great presentation.
Thank you so much, Dr. Kalamama. Okay, Dr. Bito, I don't know if you want to react. If you don't, then we'll go on to our teachers. You want to react to that?
No, I've noted the correction. I will update them.
Okay, thank you so much. Thank you so much. Okay, so now I'll hand over to our teachers. Ma Christabel.
Okay.
Hello, Ma.
Yes, I can hear you. It was a wonderful presentation. It came to time, and I must appreciate those that ask questions. This particular discussion is quite interactive. Things we love to see. So overall, I really must appreciate everyone for their input. I don't know if Chief Chitu,
I want to
go ahead,
hello,
sir.
Doctor. So yeah, thank you for the presentation, Dr. Bitoye. I think I just felt as if the aspect of raising intracranial pressure was not highlighted enough, especially in your diagnosis. If you look at the information given, look at the elevated blood pressure and then look at the pulse rate. It was as if they were describing a Cushing's reflex. Pulse rate was 60, blood pressure was quite high. So I felt that there might be a need to bring it up even in the diagnosis. Okay, as part of the diagnosis, complicated by raising intracranial pressure. Okay, so and then again, in this kind of scenario, managing the raised intracranial pressure might be more important than managing the blood pressure. Because if you manage the raised intracranial pressure, the blood pressure might come down on its own. Okay, especially for example, what if this patient had a massive or an extensive ischemic stroke with raised intracranial pressure? Okay, so the raised intracranial pressure that they are even putting in the question itself, because that's what they described was definitely a Cushing's reflex. So managing it could have been critical, even as you are thinking about the antihypertensive therapy. So, but when you manage that quickly, you might be surprised that your blood pressure will start falling, and there might not be it might not be so necessary to be that aggressive with antihypertensive therapy. Okay, so I think that's just what I wanted to point out. Thank you.
Thank you very much, Dr. Remigos. I'm grateful.
Thank you so much, sir. Thank you, Ma. Okay, Ma. Can I move on?
Yes, you can. I don't think anyone have anything to say. Thank you.
Okay, thank you so much, Ma. All right, so we'll move on to practice question 3, and to be taken by Dr. Ijoma Agbara. Okay, Dr. Ijoma, you have the floor. You have just 10 minutes. Thank you.
Good morning, everybody. So I'll be taking practice question 3. And the question reads, a 52-year-old man presented with a 2-day history of upper abdominal pain. The pain started insidiously, dull in character, and located at the upper abdomen towards the center. The pain has been unrelenting with the intensity gradually worsening, reaching 8/10 threshold about 8 hours after onset. The pain radiates to the back, worse by food, and relieved a bit by sitting up. He noticed his body has been warm since yesterday, but no chills and rigor, no change in bowel habits. He moves his bowel usually once a day. He feels a bit breathless on exertion, but no autopnea, PND, or cough. He took antacid without relief. He's known hypertensive and diabetic on telmisartan 80 milligrams daily and metformin 1 gram daily. And his GP told him both diabetes and hypertension are well controlled. He was never admitted in the past. He takes 3 to 4 bottles of beer per day and sometimes take hot drinks since his final year in secondary school. He never smoked. He's married in a monogamous setting with 3 children, no MSP. So the questions are, what are the likely diagnoses? B, what is this patient? C, list 6 etiology of this condition. And D, list the principles of management. So the first question, what is the likely diagnosis? Considering the clinical scenario painted, the upper abdominal pain, not relieved by antacid, not relieved by, my likely diagnosis is acute pancreatitis. Then the second question, list 2 investigations necessary for diagnosis of this patient. I would like to do a serum amylase level and a serum lipase level. The third question, which says, list is in etiologies of this condition. Well, there's this common mnemonics, I get smashed, which means the first idiopathic, gallstone, ethanol, trauma, steroids, mumps or malignancies for the M. Then autoimmune diseases, scorpion sting, hypertriglyceridemia or hypercalcemia, then ERCP, drugs such as didanosine, hydrochlorothiazide, sulfonamide, valproic acid, pentamidine, tetracycline, azathioprine. So list the last question, list the principle of management of this patient. Fluid and electrolyte replacement is quite important. So fluid and electrolyte replacement, pain control, nutritional support, management of complications, and lastly, management of the underlying predisposing condition. I'd like to discuss a little bit on the acute pancreatitis using the following outline, and special acknowledgement goes to Professor Abiodun Jemilohun. His slides, the 2023 update course, West African update course, was quite handy in preparing these slides. So as a way of introduction, acute pancreatitis is an inflammatory condition of the pancreas characterized by abdominal pain and elevated levels of the pancreatic enzymes in the blood. In acute pancreatitis, the enzyme also digests the pancreatic gland. However, the gland heals without affecting its function or structure. But this condition can be prolonged or could be severe, such that the function and structure of the pancreatic gland gets affected. By that time, we'll now be dealing with a chronic pancreatitis. The epidemiology, its incidence ranges from 4.9 to 35 per 100,000 rates of obesity and gallstone. Males are more affected than females, and alcohol is the most common cause in the males, whereas biliary tract disease is the most common cause in females. This is just the recap on etiology, the I get smashed, the mnemonics. So gallstone is the most common cause of acute pancreatitis worldwide, and it accounts for approximately 40 to 70% of cases. However, only 3 to 7% of patients with gallstone would come down with acute pancreatitis. The mechanism is not completely known, but it's said to involve an increased pressure in the pancreatic ducts, which causes an obstruction at the ampulla due to the stone or edema. Then this ductal hypertension results in a premature activation of digestive enzymes from the acinal cells. Alcohol is the second most common cause, accounts for approximately 25 to 35% of cases. However, only 10% of patients with alcohol use disorder would come down with acute pancreatitis. And the risks of developing acute pancreatitis is dose dependent. ARCP accounts for 4% of cases, trauma 1.5%, idiopathic less than 10%. Then these are some drug causes of acute pancreatitis, and drug causes generally accounts for 2% of cases. The lists are shown here as azithromycin, the danosine, estrogen, antibiotics, and others. These are some less common causes of acute pancreatitis and include infections like mumps, Coxsackie B, viral infection, HIV, adenovirus, pancreatic tumors, then some hereditary causes when there are some gene mutations as shown in the slide, then some congenital pancreatic abnormalities like pancreas divasium and annular pancreas. So these are some congenital causes. Metabolic causes like hyperglycemia and hypertriglyceridemia, venoms from scorpion or some spiders when there is a dysfunction in the sphincter of Oddi, vascular abnormalities, and autoimmune disorders. Pathogenesis of acute pancreatitis. Now, regardless of the etiology, what happens is that there is an increase in intraacinal activation of trypsinogen to trypsin, which overwhelms the natural removal mechanism. Now, this activated trypsin goes ahead to trigger the release of many other enzymes from their inactive forms, like the chymotrypsin, the elastins, and phospholipases. The trypsin also activates the coagulation cascade, the complement system, triggers fibrinolysis, and the kallikrein-kinin system. All these systems activated will lead to pancreatic autolysis. Now, the molecular fragments resulting from all these systems that have been activated would go ahead to attract inflammatory cells, especially the neutrophils and the macrophages. The neutrophils will end up releasing superoxides and proteolytic enzymes, whereas the macrophages will release further cytokines that will mediate both local and systemic inflammation. The acute pancreatitis increases the risk of infection by compromising the gut barrier, leading to bacterial translocation from the gut to the lumen. From the gut lumen to the circulation. Important signs and symptoms I would see on this patient, in a patient with acute pancreatitis, include severe epigastric pain that radiates to the back, usually relieved by leaning forward. There is nausea, vomiting, diarrhea, loss of appetite. There could be fever and chills and rigor, and there could be cardiovascular shock, abdominal tenderness with guarding and rebound tenderness. Great tonal sign or colon sign may be seen, but usually seen in severe cases. Great tonal sign is ecchymosis around the flank, as seen on this patient, whereas colon sign is ecchymosis around the periumbilical area. So these are some severe signs seen in acute pancreatitis. So then laboratory investigation, very important, is the amylase, serum amylase, and lipase level. The serum lipase level, okay, these enzymes are usually elevated and would trigger the suspicion of acute pancreatitis when this is seen with severe abdominal pain. Serum amylase is usually elevated, but is markedly elevated, but usually not so specific as the serum lipase. Now, we have some reasons why we may have some false positive elevated serum lipase, and they include salivary gland disease, intestinal obstruction, mesenteric ischemia, tubo-ovarian diseases, and macroamylasmia.
Please, you have 1 more minute.
Okay. The serum lipase may be elevated for up to 12 days, and the degree of elevation does not really correlate with severity. Other investigations that could be done, full blood count, serum electrolytes, serum calcium, and hyperglycemia could be there, and glycosuria. Hyperglycemia may result from the destruction of the beta hemolytic cells and leading to the hyperglycemia that could be seen. Serum calcium, there may be hypocalcemia, and this may be due to sequestration of the calcium within the necrotic fats. So CT scan is important, but not necessary in mild cases, and may reveal fluid collection, necrosis, and others. Genetic study, we are thinking of an inherited disease condition. Now, the American College of Gastroenterology Diagnostic Criteria, this is quite important. And we need two out of three of these criteria to make a diagnosis. Abdominal pain that is consistent with acute pancreatitis, when there is elevated serum amylase and lipases, and this should be greater than 3 times the upper limit of normal. Then characteristic findings on abdominal ultrasound scan. It's important to know that the abdominal imaging would only come into play if the diagnosis is still unclear, such as if the serum enzymes are not as elevated up to 3 times the upper limit of normal. So we may want to go ahead to do imaging. We have plenty severity scoring system and helps us in management of this patient. The common ones are the Atlanta classification of severity, Ransom score, Glasgow prognostic criteria, the Apache 2 score, and the CT severity index. These are some other ones not so common, and we have some single parameter biomarkers that when elevated, it's a pointer to an increased severity. These are some differential diagnoses ranging from acute cholecystitis, peptic ulcer disease, inferior myocardial infarction, and others. Management, it's key, just like we mentioned earlier in the principle of management. Fluid replacement is quite important because these patients usually lose a large amount of fluid into the TET spaces. So prompt and aggressive fluid replacement within the first 24 to 48 hours is important. Sometimes they may even need to pass a central venous pressure line. The fluid, commonly used fluid are normal saline and Ringer's lactate. The Ringer's lactate has been associated with a reduction in the overall inflammatory response. However, it should be avoided in patients with hyperkalemia. Hypercalcemia. Pain control, usually with the use of opioids, nutritional support. We may need to support this patient's nutrition, and oral intake is usually encouraged in patients with mild acute pancreatitis, usually as soon as possible, as soon as this patient can tolerate orally. Enteral feeding with the use of nasogastric tube or nasojejunal tube in severe cases. Usually, total parenteral feeding should be avoided except when there is gut failure. IV antibiotics would only come in handy if there are evidence of ongoing infection. Then management of the complications, such as we may need surgery to drain the abscess formation or to carry out necrosectomy to remove the necrosed tissues that are formed. Then it's also good to manage the underlying predisposing condition, such as discontinuing the offending drugs, cholecystectomy in patients with gallstone, treatment of hypertriglyceridemia, normalizing the serum calcium, alcohol intervention, such as in these patients when there is an unhealthy use of alcohol. These are some complications that could be found in these patients. Also, this hyperglycemia, retinopathy, and lastly, chronic pancreatitis could be a complication. This table just tries to explain why some of these complications come about, as seen on the table. This is still a continuation. Then prognosis, overall mortality is about 10 to 15%. And patients with biliary pancreatitis tend to have higher mortality than those with alcoholic pancreatitis. Mortality is about 30% in those with severe diseases. And earlier on, those with severe disease basically accounts for about 20% of cases, whereas mild is usually about 80% of cases. In the first week, death is usually from multiple organ failure, whereas in the subsequent week, infection plays a more significant role, but organ failure still continues to play a major role. So these are my references. Thank you.
Wow, thank you so much, Dr. Ijoma, for that very lucid presentation. Wow, so a very beautiful one. Okay, so now we'll take comments and questions from the participants first, and then our teachers. And please, let's keep the thanks coming. A very beautiful presentation. Okay, so We have a few comments on the chat. Okay, so Dr. Olaitan Abimbola is saying, thank you so much for the presentation. Can aortic dissection be a differential in this patient? Dr. How do you want to react to that?
Okay, yes, it is. It's a differential. It's actually on my side, but so we have yes. There is aortic aortic aneurysm and dissection. Yes, it's a differential. It can be a differential in this patient. Thank you.
All right, thank you so much. Dr. Justice Ibiti is saying, thanks so much for a concise and lucid presentation. Well done. Just a few comments for the answers given. Telmisartan and metformin are also implicated in acute pancreatitis, and it will be good to mention that. Okay, so you add it to the slide. The choice of fluids, ringers or saline, and the rate of administration is also very important as well as periodic evaluation to grade or upscale the patient's care. The breathlessness might be a pointer to pleural effusion and should be worthy of mention. The fever may be an indication for antibiotic use. So thank you so much. Thank you, Dr. Justice. So he's adding that. So just take note of those additions. Dr. Bass is saying, thank you so much, Chief Informer, for that extensive presentation. Dr. Mahmoud Jafar is saying, thank you so much. This is Gastro Made Easy. Dr. Felix saying, very good presentation. Thank you so much. Dr. Nelly Mineka, thank you for a detailed presentation. Please, what are the specific ultrasound findings used in the diagnosis for acute pancreatitis? Okay, would you like to react to that? Hello, Dr. Ijoma.
Okay, thank you. Okay, thank you for that. Actually, it's usually CT scan, at least from my literature search. What I saw was more of CT scan or MRI. And most times in mild cases, you may not really see anything. That's why it's not commonly indicated in mild cases, but it's very good in picking up, especially when complications or when it's severe, like fluid collections, necrosis, abscesses. You can find cirrhosis, phlegmons, and which are basically inflammatory masses. So these are what one may see on abdominal CT scan that will give you a pointer that we are likely dealing with a severe acute pancreatitis. All these things are around the pancreas. Thank you.
Okay, thank you so much. Okay, maybe a gastroenterologist will tell us more about the ultrasound or add more light to that. Okay, so Dr. John Adiboka is saying, wonderful presentation.
It's also good to know that the pancreas is more or less like a retroperitoneal organ. So it may not be so easy to pick up important features using an ultrasound scan. So that's why perhaps CT scan, something more advanced would come in handy. My thoughts though. Thank you.
Right, thank you so much. Okay, so Dr. Beck is saying, beautiful presentation. What's the imaging modality of choice? I think she just answered that now. That will be a CT. Okay, so Dr. Wick is saying, thanks for MRI. Okay, thank you for the beautiful presentation. Dr. Lalikan says, thank you. And a lot of thanks, Dr. Florence, Dr. Schreiber, Dr. Suri, Dr. Pute. They're all saying thanks. Presentation was very detailed. Dr. Rita Wakama is saying thank you. Dr. Bode John, Dr. Amosu Bosede, Amodu Bosede. Dr. Maruka is saying thanks. Dr. Kalama is saying, please, why do we prefer enteral nutrition? Do you want to react to that? Dr. Ijoma, it seems like you're muted.
Oh, sorry, I was even talking. Sorry, I was actually muted. Well, most times oral and enteral feeding is preferred to parenteral feeding. I think I'm not so sure of the exact reasons, but I think it's good to continue. Oh, sorry, I'm not so sure. Maybe let's continue. I may just get up the answer. Let me just look up one or two things. Sorry about that.
Okay.
Hello, Chief. Apologies, I have a morning meeting. Can I just make a comment in that regard?
Thank you so much. But did you mention your attention again?
Dr. Justice, is that you? Dr. Okele, let Dr. Justice speak quickly.
Okay.
To make his contribution.
Okay,
Go ahead.
I apologize. I actually have a meeting I'm running to. So for the first one, the ultrasound scan, yes, just like she said, it's not diagnostic. However, you could actually get a peripancreatic fluid, like she mentioned, and you could also have an idea of some of the etiology, like presence of gallstones, which, like you mentioned, is actually one of the commonest causes, and that'll give you a clue. And then, just like she said, the CT scan MRI is actually more diagnostic. Then the anterior feeding is actually preferred to parenteral because it then helps you with stimulation of release of cholecystokinin that will cause the gallbladder to compress and release its contents. If you do parenteral, you bypass that effect and then you have a filled gallbladder with risk of sludge and a worsening of the pancreatitis. Thank you very much for your presentation and all the other things. Thank you very much.
Oh, thank you so much. Dr. Justice, quickly. Sorry, Dr. Justice, quickly, a quick one. So we're not supposed to mention NPO in this case now.
Well, no, you can actually. You have to now first state that in severe cases, when they cannot take orally, you commence on nil per os initially. But the moment they're able to take orally, you commence feeding. Now, the options are either the direct oral feeding they can take orally or a nasojejunal tube to feed them. You can.
Oh.
But for this particular patient, another thing you must mention is the fact that they're giving you some features already. First, the person's age and all. So the picture is not really looking like a severe pancreatitis. And you should state that as well. Because when you're managing the person, you have to just stage that person as well, or grade the person by your initial ransom or BSAP score. So that will give you an idea of what to do immediately. And that's how to tell you the level, whether you're going to manage this patient in the ICU or going to manage the person in the open ward. And then when you're evaluating, sorry, let me just add that when you're giving your fluid therapy, you're evaluating every 6 to 8 hours where you're doing your electrolyte urea and creatinine, check your blood urea, nitrogen, full blood count, where you're trying to check if the PCV is rising. Because you would expect that with rehydration, there should be some level of hemodilution. If that is not occurring, then the person is not improved. Then you upscale, move the person to ICU. Thank you very much.
Okay, well, thank you so much, Dr. Justice, for that beautiful input. Okay,
Thank you so much.
Okay, I think what Dr. Justice has already mentioned, it's abdominal ultrasound findings and enlarged heterogeneous pancreas, which shows anterior bowing and surface irregularity, surrounded by rim of peripancreatic fluid, then dilated common bile ducts and pancreatic ducts, multiple gallbladder stones. Okay. So parenteral nutrition can also provoke a pro-inflammatory response and promote sepsis. Okay, thank you so much, everyone, for the beautiful comments and for the thanks. So let me go to okay, I can't see any hands up. So I will just go straight to.
Hello?
Yeah.
Hello,
Okay.
good morning.
Good morning, ma'am.
I'm so sorry. This is Dr.
Good morning, Ma Cookie.
Yeah, this is Dr. Cookie. Please, can I come in? Okay,
Ma,
so
please
I
go
want
ahead.
to
Thank you
first
so
start by, yes, I want to start by thanking the presenter. She did a very wonderful job. So I think everybody that has also spoken has contributed well. So I just want to throw a bit more light to just a few of the controversial areas. So just as you said, there are different imaging modalities that can be used in acute pancreatitis, making the diagnosis, and then of course to also prognosticate and help in the scoring system as per the severity. So the abdominal ultrasound scan, we said, is of limited utility, because as she said, the pancreas is a retroperitoneal organ, and so it's not going to show easily. And then if there's a lot of gas in the stomach, it's going to obscure the pancreas, but it is useful it's actually the imaging imaging modality of choice for gallstone disease. So if that is the cause of the acute pancreatitis, it would show it. So rather, in making a diagnosis, we use an abdominal CT scan. That is better. Then apart from an abdominal CT scan, you can do an MRCP in those patients. And then you can also do an endoscopic ultrasound scan. Fortunately, it's not available in our environment. So the other thing I'm going to touch on is the issue of feeding in patients with acute pancreatitis. Formerly, the old teaching was that in patients you would withhold nutrition, as in oral intake, as in you place them on NPO. That used to be the mainstay of initial therapy for acute pancreatitis.
why this was done was they thought that, because of course when you eat, it's going to stimulate the exocrine pancreas, to secrete the pancreatic enzymes, and it's actually acute pancreatitis is as a result of autodigestion of the pancreas from the pancreatic enzymes being activated within the pancreatic duct instead of coming into, because usually the pancreatic enzymes will come out through the ampulla of Vater into the second part of the duodenum, and then trypsinogen is going to activate them. But when this activation occurs prematurely within the pancreatic duct, that will now lead to acute pancreatitis because of the autodigestion of the pancreas. So it was felt that when you feed them, that is going to stimulate these enzymes that will now start the process of autodigestion, and then of course they will have worsening of the abdominal pain, the nausea, the vomiting, and then it will also worsen the pancreatic inflammation. But now the enteral feeding, is thought to maintain the health and the barrier function of the bowel wall. So it's so one of the reasons that if a patient is, the acute pancreatitis is very severe based on your scoring system, you can place the patient on NPO and then still give fluids, because hemo concentration, one of the complications of severe acute pancreatitis is actually AKI, and then these patients can actually develop renal failure. Acute tubular necrosis can occur, and this can, worsen and then of course the patient can go into shock too. So this can worsen the outcome and increase mortality. But when you start to feed them, you are going to maintain the health of the bowel wall, and then you are going to reduce the probability of bacterial translocation and subsequent superinfection of the pancreatic fluid, and there's of the pancreatic fluid collection because of the inflammatory processes that occur. So that's why early nutrition is actually, enteral nutrition is actually advocated in acute pancreatitis after you have stabilized these patients. So I think that was just what I wanted to add to what everyone has said. Thank you.
Thank you so much, ma'am. Thank you so much, ma'am. Marcus, I don't know. Okay, I can hand over to you.
Tekele, your voice is a little muffled. I don't know. I didn't get you well.
Okay, but I want to hand over the class to you. I don't know if we have more comments from our teachers.
Chief Remigus, Chief Tutu, any comments before we close the class?
No comment, so I'm okay. After Chief Kara, who wants to talk again? Chai.
I understand she has added T's, dotted the I's and crossed the T's. And I must appreciate the